Okay.
Okay, dear colleagues, I would like to thank the organized committee, Dr. Patakos and Dr. Sparias. I'm sorry I couldn't be there with you. So my presentation is left atrial appendage sync procedure or concomitant catheter ablation. I will begin. Atrial fibrillation, we know that it is the most common cardiac arrhythmia and the major risk factor for thromboembolism. And catheter ablation for atrial fibrillation is recommended as a first-line option by the latest guidelines to prevent AF recurrences and improve quality of life in symptomatic paroxysmal or persistent atrial fibrillation. However, guidelines recommend the continuation of long-term anticoagulation in patients after catheter ablation with a high stroke risk, irrespective of the rhythm outcome and successful ablation. And a significant proportion of patients have limited anticoagulation options due to contraindication, for example, a history of bleeding or high bleeding risk, or a high risk of stroke, patients who experienced a stroke under anticoagulation, or side effects, or there is a tendency from some patients who want to discontinue anticoagulation. So left atrial appendage occlusion is an option for these patients, for patients at high bleeding risk. Many studies and data demonstrate that appendage occlusion significantly reduces stroke risk compared to the expected risk based on the Asvestas score. And the question is if the combination of these two procedures is effective and a safe strategy, and can the combination of these two procedures can improve the prognosis in patients with a high risk of stroke. Indeed, as both AF ablation and percutaneous left atrial appendage occlusion require transeptal access to the left atrium, the combination into a sync procedure may offer a straightforward strategy, leading at both rhythm control and stroke prevention without having the additional risk of multi-procedures and complications, and with a high device placement success rate, as shown in this study, about 97% in implantation of a Watchman Flex device. A very important trial recently published in the New England Journal of Medicine is the OPTION trial. The aim of this study was to determine if left atrial appendage closure is a reasonable alternative to anticoagulation following AF ablation. So patients randomly underwent left atrial appendage closure, the device group, or received anticoagulation, the anticoagulation group. The results of this trial showed that the device group was associated with a lower risk of non-procedure related bleeding than the anticoagulation group, and also was non-inferior with respect to a composite endpoint of death from any cause, stroke, or systemic embolism at 3 years. Another important sub-analysis of the OPTION trial included two patient cohorts. The first sequential arm, there were patients who had an ablation 3 to 6 months prior, and these patients were randomized to device implantation or continued anticoagulation. And the concomitant arm, patients who were planning to undergo ablation, were randomized to device placement or continued anticoagulation. And as you can see, the 3-year efficacy was similar between the Watchman Flex device and anticoagulation in both arms, maintaining the safety the safety advantage of the device in reducing bleeding risk, regardless of whether the ablation and the left atrial appendage closure were performed in a concomitant or sequential manner. So choosing a concomitant procedure does not appear to increase adverse effects. Simultaneous AF ablation and left atrial appendage occlusion can be performed within a short overall procedure duration. According to this study demonstrated that adding the device increased the procedure duration by no more than 20 minutes, while also reducing the fluoroscopy time. However, there are some concerns with concomitant procedures. The first is the presence of sometimes edema in the pulmonary reeds. So the question is to upsize the device. This option can lead to device dislodgement, increased pressure, and increased risk of perforation. Deep device implant has been suggested, but there is a higher risk of device-related thrombus due to larger uncovered areas of the left atrial appendage. And here is a case report, 2 cases published in JACC, which demonstrates the edema of the reeds and how the reeds of the ostium of the reeds and the ostium of the appendage changed in dimension before and after cryoablation. Secondly, there is increased risk of device-related thrombus and subsequent thromboembolism due to ablation edema resultant endothelial dysfunction. Third, for the transeptal puncture, current AF ablation techniques often require a less posterior transeptal access than what is optimal for device implantation. And this can sometimes make the procedure more challenging. Some studies have shown a slightly higher rate of minor leaks in the concomitant procedure. And finally, the device itself may act as a trigger site for atrial fibrillation in some cases. Nowadays, pulsed field ablation, PF ablation, appears to be a promising alternative to thermal RF or cryo, and PFA is a more controlled form of energy and does not damage adjacent structures. The question is if there are advantages with PFA in combined procedures. The possible advantages can be that it's a single short procedure, providing shorter procedure times. Also, transeptal puncture can be performed in a more suitable position for left atrial appendage access. Also, PFA is a more tissue selective form of energy, and this theoretically can lead to a lower risk of certain complications in a combined procedure. And the question is whether PFA can create less edema in of the reeds in the left pulmonary vein, and consequently decrease the risk of peri-device leaks. This recent study included combined and standalone PFA and left atrial appendage occlusion procedures, and found similar acute success rates of left atrial appendage occlusion in both groups. The study found that in this study, the pulmonary reeds thickness increased after ablation by approximately 69%. And at 3 months, the rate of peri-device leaks did not differ significantly between the combined and device alone groups. However, a significant link, more than 3 millimeters, occurred more commonly in the combined group compared with the standalone left atrial appendage occlusion group. And there is a study diet. In this study, the aim of the study was to determine the effects of ablation first compared to occlusion first strategies in patients who underwent combined procedure. And they found that the incidence of chronic PDL, the chronic presence of leaks, was higher, 3 times higher in the ablation first, 15% versus 5% in occlusion first group. In summary, combining AF ablation and left atrial appendage closure in a one-stop approach is effective and safe for achieving successful PVI, successful AF ablation and left atrial appendage occlusion implantation. It may provide a way of addressing arrhythmia burden, stroke risk, bleeding risk simultaneously in appropriate patients. There's a higher incidence of mild or moderate leaks in patients post-ablation, and we need further research to clarify the beneficial role of the combination of these procedures and assess long-term outcomes. Thank you very much.
Very much, Dr. Asvestas. We have just a very few minutes. Dr. Mavrogianni, your comments?
Could I have a photo, please? Yes. Thank you so much. Just a few notes. Dr. Zefas, I loved your talk. This is a very specific